All right. Well, hello, everyone. Welcome to the Lown Institute's 2023 launch of America's most socially responsible hospitals. My name is Vikas Sani, and I'm the president of the Lown Institute. This is our fourth year of publishing the index. We're really happy to see folks from all over, from hospitals, public health departments, patient advocates, physician organizations. And we clearly have people from all over the country, in New York, Philadelphia, other cities, both coasts. So welcome, everyone. So as most of you know, here at Lown, we believe that people have the right to a healthcare system that provides high quality, affordable, equitable, and just healthcare with a human connection. The biggest obstacle to achieving this, in our view, is really the profit-driven nature of our healthcare system today. Even though we spend more on healthcare than any other developed country, as most of you probably know, and as you can see on the slide, we get significantly worse results in many areas. What's interesting to me is always that this wasn't always true. We became an outlier over the last 30 to 40 years. We live shorter lives. We have higher rates of preventable harm, like maternal death. Millions of people are bankrupted by medical debt, and clinicians are rapidly losing faith in their activity, in their profession. COVID-19 was clearly a wake-up call for us in the US and around the world, but I think we've started to ignore that call. Instead of transforming our system, we went back to business as usual pretty quickly. We think if we want to turn things around in healthcare, hospitals will need to be a big part of the change. Hospital spending makes up nearly a third of all healthcare spending, and so hospitals are a huge player in the sector. Everyone who knows or has been to a hospital knows they provide essential services, and many are so complex you're not going to find them anywhere else. But hospitals are more than care providers. They can make decisions that impact the everyday lives and well-being of the community around them, like how much they spend on financial assistance, how well they serve the entire community, how much they pay their workers. So when hospitals are socially responsible, more people have access to the care they need. They become healthier and they worry less. Communities are better able to flourish. Health professionals are happier with their jobs, and our nation grows stronger. So at the Lown Institute, we're working to lay the foundation for just such a new healthcare system through projects like the Lown Hospitals Index. We developed the index to help hospitals, communities, and policymakers have more data and give them something that measures what matters. That means not just outcomes like patient safety, mortality, patient satisfaction, readmissions, though they're very important, but also health equity metrics like racial inclusivity, community benefit spending, and metrics of value like avoiding overuse and cost efficiency. So on the Lown Index, performance on equity, value, and outcomes together determine the hospital's social responsibility grade. So in total, we have about over 50 metrics, and they're available for more than 3,600 hospitals nationwide. So all of them are based on publicly available data. There's no popularity contest. There's no opinion, survey, reputational piece to what we report. Another thing to point out is we've always used 100% of traditional Medicare claims, 100% fee for service. That by itself is a massive data set. But this year, we've doubled it by adding Medicare Advantage. As some of you know, Medicare Advantage is projected to cover 70% of all of Medicare by 2030. So any ranking that doesn't include it is missing a lot of data. So, which hospitals made the grade on equity, value, and outcomes? We'll be revealing our top 10 hospitals in just a minute, but first let's introduce our esteemed guests. So Veronica Flores, the CEO of Rising Communities, formerly Community Health Councils, which serves South Los Angeles and beyond. In this role, she leads the organization's work to build equitable systems for health in partnership with community leaders. In her 30 years as an activist, entrepreneur, and nonprofit executive, Veronica has focused on disrupting and dismantling inequitable systems of health. Excuse me one second. Wait. Donna Lynn from Denver Health couldn't be here today, but we're lucky to have Reed Pierce, MD, Denver Health's Chief Quality Officer, and he's here in her place. Dr. Pierce oversees the health system's quality programs in clinical side and patient safety. He's passionate about improving value-based care, experience, equity, and workforce satisfaction. Dr. Pierce was previously at Dell Medical School, University of Texas, Austin, and before that, University of Colorado. New York City Council member Julie Menon represents the Upper East Side. An attorney and civic leader with over 2 decades of experience, she most recently served as the city's census director, and there she achieved a historically high self-response rate. In 2023, she led the effort to create legislation establishing the nation's first municipal Office of Healthcare Accountability to improve price transparency and affordability of healthcare in New York City. So welcome to all of you. Veronica, I just wanted to ask you, a quick first question. One of Rising Community's top policy priorities this year is health equity. What's one project your organization is working on in this space that you want to highlight or share with us?
Thank you, and hello to everyone, and welcome to this amazing opportunity to discuss something that is so critical in our community. So thank you for that. We have been working, Rising Communities, formerly known as Community Health Councils, has been around since 1992. And the reason that we were created was right after the uprising in South Los Angeles in 1992. And we were created as a body to really look at healthcare inequities. So this is in our DNA. And because we had the ability to bring together diverse sectors for discussions that would lead to policy changes. So that was the original creation of our institution. Since then, we've been involved in, when ACA was coming to California, we've done lots and lots of coalition building. We have 2 major coalitions. So there's a lot of work that continues to happen in the space of healthcare. But, and we always think about the social determinants of health as how we approach health. But a few years back, we decided to really start to look at healthcare a little bit different. So this brings me to what we're doing today that I want to highlight. So a few years back, we looked at if we really are trying to understand the system from a holistic perspective, we can't just think about healthcare delivery and healthcare access, but what does access really incorporate in that? And then inequities are what really comes out of all of that. We do significant research in this area. And so what we came to is, okay, since we always work in partnership, we partnered with LA Care and the Federal Reserve of San Francisco. Unusual partners and coming together, but the idea was to really look at the last time we had a recession in this country. The greatest impact was on communities of color and people's healthcare. So we wanted to look at recession and how recession would be different or could be different if we started to look at the players in this space. We moved into then doing a study to find out, what is it that people really experience when we start to look at healthcare. We found out that it doesn't take much. It's around $435 a month. We then move into creating a guaranteed basic income. But once we got to the point of really moving into our research and we got to the hospital side, this is where our work really came to an end. Because what we found was that 4 years ago is when we did that. 4 years ago, we came to an end because as hospitals are designed, we really had no entry, right? The methodology for even taking on policy work around hospital debt or how hospitals use community benefits or how they even interpreted the data that they supposedly have to collect around their health assessments was really lacking on equity, right? The equity measures that really need to be followed. And so at that point, we came to an end. We met with significant stakeholders and they said there's really no legislation. So I applaud Julie for doing this thing in New York, because it was really, it was really groundbreaking. And so we need to applaud people like Julie so that we can have other things in this city and other cities. So that's really where we're going to focus again. Now the County of Los Angeles and the state of California are all in step. Right now, we're really ready to look at hospitals to then connect the data and really understand how clinics also play a role in the relationship around equity.
Thanks, Veronica. That's terrific. It's pretty exciting to hear about your work. So let's turn to you, Reed. You're relatively new at Denver Health. I don't remember exactly when you joined, but what's been your top priority as the Chief Quality Officer there?
Yeah, thanks, Vikas. Before I jump into the question, just gratitude to you and to the Lown Institute, both for what you all have been leading in the country for many years now. This conversation about value and equity is so important. And I've really admired the work over the years. Always happy to have Denver Health be included in that conversation and recognized for things we're doing. Also want to give a very brief shout out to our CEO, Donna Lynn, who wanted to be here and can't be here, to some of the conversation we're going to get to. How do we advance this work? How do we do work in partnership with those who make policy? Donna got a call yesterday from our new mayor saying, hey, could we meet tomorrow and talk about advancing housing in the city for those who have housing insecurity and or experiencing homelessness? And Donna said, I could be here and talk about this, or I could be out and doing the work. And she said, I'm going to do the work. The short answer, because, what's the top priority for me, and I've only been here about a month, is whatever Donna wants to lead us to do, that's what we get behind. She is an extraordinary leader around these topics. We are, of course, really focused on a lot of things other health systems are: high quality, safe, value-based care, financial stability coming out of the COVID pandemic. But I would say that the two that keep rising to the top, and this is certainly reflected in my work, number one, how are our employees doing, and how can we meet them where they are and be responsive to them? Because they are the energy of the organization. The people who work at Denver Health are a reflection of our community. They are the connection to our community. They are often the bridge to partnership in our community. And so without them, we cannot do the work that I know we're going to talk about today. We're also in the process, and I'm trying to do this actively as a brand new person, of assessing which structures, which legacy cultures are strong and are helping us do this work that's important to us. And as we emerge from the pandemic, where do we need to lean into innovation to do things that we've maybe had on hold for the last 3 to 5 years because it's been a busy time. We've had to focus on some other things. So those are the top priorities. Really going back to the workforce, though, that's been very important to us in the last 6 to 12 months.
Great, thanks. Yeah, we've been hearing a lot about that issue all over the country. So, Julie, you led the effort to create the New York City Office of Healthcare Accountability. So it's the first of its kind for a major metro area. What were the main drivers behind the effort, and what's been the reception so far?
Well, first of all, thank you so much for having me today, and it's wonderful to be on this panel with the other panelists. This has really been a labor of love. This is an incredibly important issue of equity, of transparency. I began my career as a healthcare regulatory attorney. I've been a regulatory attorney for over 20 years, and I also formerly served as commissioner of the Department of Consumer Affairs for New York City. So this issue of a lack of transparency around hospital pricing is fundamentally a consumer protection issue. And really, if you think about it, there is simply no other industry where you as a consumer are procuring a service, and yet you have absolutely no idea, albeit at your most vulnerable time when you're in the hospital, what you are going to be charged for that very service. So to put an example on it, a New York City specific example, if you're a woman and you're giving birth by C-section and you go to Montefiore Hospital, which is in New York City, you will get a bill for $55,000 for that C-section. If you go to another New York City hospital, one of our public hospitals, you will receive a bill for around $15,000. So there is an enormous discrepancy between this, and I could give, that's one of numerous hundreds of examples that we all know exist. So this becomes a consumer protection issue, and I became very interested in this idea of how could we as a city legislatively approach it. I think it's really, quite frankly, up to cities. And I formerly used to teach a class at Columbia called When Cities Take the Lead, which is about how municipalities, cities can take a leading role when the federal government is deregulating or not doing what it's supposed to do, and the states are deregulating. Here we have a perfect example of this. We have a federal rule which requires hospitals to disclose their prices. In New York City, only 6% of hospitals are complying. So I really felt it was incumbent upon New York City as a city council to take the lead on it. And you asked how the reception has been fantastic. I want to say from the outset, we've had a phenomenal coalition behind this, a coalition of leading labor unions like 32BJ and DC 37, which are two of our largest labor unions in the city, got behind this legislation from the get-go. I had a supermajority of my colleagues who signed on to the bill. That was very important. So we had a veto-proof supermajority. The mayor of New York City, Eric Adams, was very supportive of this legislation. So the reception has been tremendous, and I'm really just incredibly excited about the future for this office.
Great, thanks. Well, we'll all be staying tuned to see how it goes. I think it's time for a countdown, but before we get to the countdown, just a quick plug. If you're interested in all things hospitals, and you probably are if you're here with us today, you won't want to miss Hospitals on Purpose, our monthly newsletter. So to be the first to hear about our new data releases, blog posts, and news in the hospital space, you can go and sign up at lownhospitalsindex.org/subscribe. So please do that if you haven't. And now, the moment we've been waiting for, out of the thousands of hospitals we rank, just 54 got a spot on the Lown Index honor roll by receiving A grades on all the major categories of equity, value, and outcomes. In other words, these are the straight A students, class of 2023 of the Lown Hospitals Index for Social Responsibility. We're not going to go through all 54, but here are the top 10 hospitals for social responsibility. Number 10, Mission Hospital McDowell in Marion, North Carolina. Number 9, St. Alphonsus Medical Center, Ontario in Ontario, Oregon. This is their second time on the honor roll. Number 8, Denver Health in Denver, Colorado. This is their third time in a row on the honor roll. Number 7, Baylor Scott and White Medical Center in Pflugerville, Texas. Number 6, St. Luke's University Hospital, Bethlehem, Pennsylvania. Number 5, TriStar Horizon Medical Center in Dixon, Tennessee. This is their second time on the honor roll. Number 4, UC Health Medical Center of the Rockies in Loveland, Colorado. This is their second time on the honor roll. And now the top 3. Number 3, Del Seaton Medical Center, University of Texas at Austin. Number 2, UC Health, Greeley Hospital in Greeley, Colorado. They're a relatively new hospital, and this is their first time that we rank them in the index. It's a pretty great start, number 2. And our number 1 hospital, Duke Regional Hospital in Durham, North Carolina. This is their third time in a row on the honor roll. So congratulations to all of them. We went through it pretty quickly, so here's the top 10 again. You can take a look. And you'll also be able to go to lownhospitalsindex.org to see the full honor roll and the rankings. So let's start with you, Reed. Congratulations on Denver Health being ranked in the top 10 again this year and being on the honor roll 3 years in a row. So it's hard to have that kind of, have a lot of hospitals that do it. So it's an outstanding result. What's your view? Like, what's your diagnosis? How does that happen? I know you have a view. You interviewed to take a job there, so you checked them out.
Yeah, thanks, Vikas, for once again recognizing us in our work 3 years in a row. Extraordinary opportunity to put a spotlight, I think, on all of those dimensions that were on the slide that was up a minute ago. I would say a couple things. First, I think of this less as a diagnosis and more of a mindset. And one of the things that was really exciting to me about Denver Health when I looked at taking my current job here is this extraordinary commitment of the people to values that are reflected at the human level and the kinds of things that were on the criteria list. So people really value inclusivity, people really value equity, people really value cost efficiency, given our role in the community. People come to work and express those values at the individual, the team, the organizational level. And so that just percolates through the entire organization. I think that creates a kind of North Star, if you want to call it. It also creates a momentum and sort of a sustainability of the energy and commitment, regardless of what strategic priorities come out every year. Those are really kind of the anchors that pull us along. The second piece, and if Donna were here, she would say this, Denver Health is more than a hospital. And we are, of course, like every other hospital, a big hospital. That is a big key part, a vital part of our care delivery system. We have clinic partners. We are tightly coupled with several dozen federally qualified health centers. We have almost 3 dozen school-based clinics. We have a lot of partnerships in the community, working on housing, working on access to food, working on transportation. And so, part of what I think makes Denver Health special in my view is that it thinks of itself as an ecosystem, and the community is a connected part of that ecosystem. And so a lot of our conversations are not only about how do we reduce, for example, preventable harm in the hospital, something that's still really important in care delivery in this country. We're also talking just as enthusiastically about how do we make sure more kids make it to school and get the outcomes they need in the education process because they've got access to healthcare at school if they need it, because they've got access to mental health, either through the Denver Health campus or one of our school-based counselors or our behavioral health specialists in the federally qualified health centers. So looking at the work we do through the lens of an ecosystem and saying, how do we strengthen that ecosystem in pursuit of health outcomes for everyone is part of the Denver Health special sauce, if you want to think of it that way.
Great, thanks. So Veronica, as I said before, getting on the honor roll is hard. And for a lot of well-known hospitals around the country, equity is unfortunately the missing piece. So for the hospitals in LA that want to do better, where would you have them focus their time and resources?
Yeah, well, I mean, I think, what Reed just talked about is exactly sort of that ecosystem. I love hearing that because that's what we keep talking about. If we don't address issues from an ecosystem perspective, then we're never going to get to the root causes. So I think, I would say there are 3 major areas that hospitals really need to look at. The first one, which goes right to what Reed was saying, is improve the racial and ethnic representation of hospitals, but not only in terms of providers, but also, one of the elements that you measure, right? Hospitals ensuring that staff is representative of the population that they serve. I mean, it seems so basic, especially when we know that evidence is showing that when there's more diversity, health outcomes are much better, right? Representation matters. And so really looking at recruitment strategies, education incentives, language barriers, cultural understanding, and retention strategies. So I would say that that's one of the key areas of making workplaces more equitable. The other thing is that, there's a way within that same area, there's a way in which we need to start thinking about pipeline development. And that not only supports the ecosystem, but it also allows hospitals and clinics to really begin to build their pipeline for the future, especially with the shortages that we have right now. And they're everywhere. I mean, we can talk about LA shortages, but they're happening around the country, particularly after COVID. Secondly, hospitals need to build the infrastructure to communicate with clinics and other providers about their patients. This is a huge issue, which then doubles the cost. The lack of shared electronic medical records or some system streamlined that can communicate across systems, it's a huge challenge for our communities. And lastly, I would say that hospitals really need to be intentional about reducing and addressing inequities. And this is around looking at the impact of climate and health around an environmental racism. That all are areas that hospitals not only can do themselves, but I think part of what Reed is talking about is that relationship with student health centers, that relationship with FQACs, that relationship with nonprofit organizations, and then government. So it's a whole ecosystem that has to work together. This would align equity policies and pursue so that hospitals would be able to be a little bit more innovative around community investments. Shared resources. I mean, there are lots of different ways where they need to look at how they're bringing in resources and then the output of resources from a hospital. So I would say those three, if we could really get that happening here, it would be amazing. You know, we were part of a huge effort because South Los Angeles, 20 years ago, had one hospital. 30 years ago, had one hospital. So it just goes back. This is the reason we were created. That was Martin Luther King Hospital. It was in such disarray. The hospital almost closed. That would have been, again, the only hospital for an entire huge community of over 100,000 people at the time. That's changed and evolved and grown. But at the time, we had to fight just to keep the hospital open. And so having this ecosystem, as Reed is talking about, would not only be safer for the community, but it also will allow some parameters for hospitals and how they operate within our communities.
Thanks a bunch. Well, Julie, when I came to Harvard to train with Dr. Lown, I didn't really realize I was coming to work with a renegade who really didn't want to do too much to people. So that's another way of saying the value of care has always been part of our philosophy and point of view. It's a big part of our index. Do you think New York City hospitals can do better on value? Do you see a role for the Office of Healthcare Accountability to help them improve the value of the care they provide?
Absolutely. So let me talk a little bit about what this Office of Healthcare is going to do. First of all, the Office of Healthcare is going to list the prices by hospital, by medical procedures, so that patients will be able to see in advance what the procedures are costing. But in terms of what you're talking about hospitals giving back and the equity piece, my legislation also requires disclosure of tax incentives to nonprofit hospitals. So in New York City, we are currently giving $1.2 billion of tax incentives to these nonprofit hospitals in the city. And as your reports have shown so clearly, the hospitals are not giving back an attendant amount of benefit in terms of community care, and they're shortchanging New Yorkers hundreds of millions of dollars. So my legislation is going to disclose that information so that the public can see that, because that is certainly salient information for people to know. Now, obviously, the City Council does not have jurisdiction over not-for-profit status, but the New York Attorney General does. And so another piece of my legislation requires reports to the New York Attorney General, who regulates all charities and all the status of all not-for-profit entities. And so that is another key piece of the legislation, another way that we can really make sure that hospitals, when they are taking these tax incentives, are giving back the true value in terms of community care. And that's something that's absolutely sacrosanct. I do want to say also the district that I represent, which is at Manhattan's East Side, is actually Hospital Alley. So in my district is New York Presbyterian and Mount Sinai and Memorial Sloan Kettering and so many other hospitals. So I have the honor of representing Hospital Alley, but there's also an attendant responsibility to make sure that these hospitals are providing the necessary amount of community care.
Yeah, that's impressive and great challenge ahead of us, I think. So our index covers a lot of different areas of equity. And lately we've been seeing and getting a lot of queries and seeing interest in executive compensation. So what's interesting to me is that our honor roll hospitals show us that you don't have to pay a CEO excessively to get the best performance. In fact, 70% of our honor roll hospitals pay their CEOs less than the average for hospitals of similar size. So, for example, our number one ranked hospital, Duke Regional, paid their CEO around $700,000 in 2020. So that's not nothing, but it's actually much less than the average for urban hospitals of that size, which turns out is about $1 million a year. And if you compare that to UNC Health Southeastern, which is another hospital about the same size in the same state, their CEO got paid about 1.24 million, but actually ranked much lower in all the indices, both outcomes, value, and equity on the Lown score. So they were at 3350, I think was their rank. So if you look at some of the largest, most prestigious hospitals in the US, there's an obvious pattern. We've been seeing it for a few years, which is that most of, for example, the US News top hospitals really do well on outcomes and on value, but they struggle with equity. And that's something we've pointed out before. At the same time, some of those are also the highest paid CEOs in the US. Now, I certainly don't pretend to know, and nobody at Lown pretends to know the right amount to pay a CEO, or even if there is one. But we think it's important to ask, what are we getting? What are the incentives? What are we getting for this compensation? And our view is that CEO pay should reflect not just hospital size and revenue, but some tangible commitment to their communities as well. So I'm really curious what you all think about this. I'll ask you a few questions. We're sort of running a bit late, so please keep your answers brief. But let's start with you, Julie. We saw some super high CEO compensation around the country, and including in New York City. Does that surprise you at all? And does it matter for New Yorkers how much we pay or for what we pay?
It definitely. Oh, yeah. So sorry, I was just going to say it absolutely matters. And when we had the hearing on my legislation, this actually came up as an issue as part of the hearing. My legislation was opposed by the Greater New York Hospital Association, vigorously and strongly opposed. And one of the reasons they said why they oppose the creation of the Office of Healthcare Accountability is they said, well, it's going to put a burden on the hospitals. The hospitals cannot afford this kind of burden. And my response is, you're saying that transparency is a burden? That's ludicrous. I mean, that's honestly insulting, that we're going to tell patients that we can't disclose the price of various procedures, that is going to cost too much, when we see that executive CEO compensation, particularly as you point out in New York, is incredibly high. So I don't buy that argument. And transparency, I also want to say, actually lowers costs overall. So I'm not talking about the CEO compensation costs. I do just want to get in the point that one of the impetus behind this legislation was to lower costs. So for example, in New York City, we just passed a $107 billion municipal budget. 10% of that budget goes to public sector employee, retiree, and dependent healthcare. We're spending $11 billion, the city of New York is, on our public sector employee healthcare. That is almost double what it was 5 years ago. So one of the real benefits of this legislation is we know that transparency lowers costs. It lowers costs for the city, it lowers costs for private sector employers, and we know transparency works. So it's a piece of this whole puzzle on the CEO compensation, because it was used as a reason to not pass the bill, and it just doesn't hold water at all.
Yep, thanks. Veronica, I mean, it seems like New York and LA may be in a kind of social responsibility competition here, but there are some policy proposals in LA right now around healthcare worker pay. One is to create a minimum wage of $25 an hour for healthcare workers. Another is to cap CEO pay at the president's salary, which is $450,000. Do you think these are good ideas? What kind of difference could policies like this make?
Yeah, well, I have to say before I respond, this was so similar. I mean, we had sort of the same reaction from private industry as we did when the $15 minimum wage started here in LA. The fight, the response from business was exactly the same. If you give someone $25 an hour, that will hurt the hospital, because the hospitals can't afford to pay that. So therefore, the cost will be higher for the patients. That was the same response the businesses were having when we were fighting around $15. That passed, that went on, it's now been moving, right? So this is the same thing. And so we're experiencing the same type of advocacy organizing that we had to do around the $15. For this one, I mean, the impact is just pretty straightforward. So for me to say it should be obvious, right? The impact is this financial incentive for workers who have been in the front line, who were greatly impacted by COVID. And so a lot of those disparities that really came so bare during COVID, we now need to think about, these are folks who are living in poverty and working 2-3 jobs just to be able to make ends meet. They have to show up to the hospitals and work. So having a financial incentive that support families, we're talking about bringing this whole entire sector out of poverty. That should be something that every legislator should be excited about, because this is how people talk about the work that they do. The other part is that we know that having lack of economic resources really creates a lot of stress, lack of access to accessibility because of lack of resources, poverty, institutional racism, lack of effective nutrition. I mean, I can go on with all of that. That really leads to an equal sign of having increased access to resources will alleviate some of that, and therefore the stress that leads to many of those health outcomes, over time can improve. We've seen that for all of our research. So I think, those are really the two main. How do we organize? We organize, as we said, we think about putting a salary cap. I'm telling you that, and as Julie said, that is the biggest fight that we will have. The other part, we've done it. We know how to approach it, but the salaries, we start getting into private industries, and so that's going to be a hard one. I know that. I don't know where that's going to go. The other one, I know we can fight it.
Yep. So Reed, I'm not going to put you on the spot and ask about your boss's salary, but I think that, what Veronica just said is interesting, because there is a dimension, especially after COVID, when we understood how essential certain essential workers are, on the issue of incentives at the lowest rung, and on incentives to reduce income inequality. Traditionally, I don't think those of us who've worked in clinical quality and safety think about those things. Do you think it's worth thinking about?
So I think it's really important, because for several reasons, building on comments that Julie and Veronica made. One is to achieve whatever our aim is in healthcare: safety, quality, value, equity, accessibility. We need systems, we need process, and most importantly, we need the engagement of our people who are there to meet patients and families where they are. When we get too far apart on the compensation issues, and people look at those numbers and say, what I'm seeing in my own health system, what I'm seeing around the country feels outrageous to me, that subtracts from the moral energy people bring to the work. So that alone for me is an important reason for us to be talking about these topics, whether it's through the lens of quality and safety or any other. The second is, and I'm not an expert here, this is just me reading over time, if we go back in history, and I was a history major in college, and you look at the performance of organizations, I think there is a very credible story to tell, where performance of organizations over time has actually been sustained when the gap between those who work in those organizations who make the lowest salary and those who make the highest salary is actually smaller than it might be otherwise in a market economy. And I feel like we're at that moment in American healthcare. You think about CEO compensation as one example. We could look at lots of other forms of compensation and turn around and ask the question, should some of that money be supporting those who are making a lot lower salaries, who are doing critical work every day? Should we be investing in things like community health workers who can go with our patients out to where they live most of their lives and make the choices that impact their health? We're going to get a lot more bang for our buck, close that gap that you showed in total health outcomes between where we are in the United States and in other countries if we bring that sort of thinking to the compensation question. So I think this is vitally important, basically through any lens that you look at in American healthcare today.
Great. Thanks. Well, we're going to move on to audience questions, but I'm just going to go off script for a minute to say something because, what we see, what we're talking about here, what we've just been talking about is really the tip of the iceberg of a conversation and of feelings in the country. And I just watching a stand-up comedian on Netflix, is the usual stuff about girlfriends and moms and this and that. And the guy, but about 2/3 of the way through, the guy talks about a healthcare experience. And then he says, American healthcare is a criminal enterprise. Now, it was shock value. What stunned me was really the audience reaction, which was loud, sustained cheers and applause. So we got to get this right, folks. To the audience, do you think, this is for you, Julie, do you think New York City hospitals are going to be more likely to comply with the local price transparency regulation than the federal rules?
Well, that's a great question. Well, clearly they're not adhering to the federal rules at all. And so we know that. And there's been, by the way, very little enforcement on the federal level. There have only been a few cases where the federal government has done enforcement. Legally, with our bill, we cannot subscribe any kind of penalties because only the state is allowed to regulate hospitals. Cities are not allowed to. So that is one of the limitations we have. However, we do believe there's going to be very strong compliance with the bill for a couple of different reasons. One, there is a shame level. If you don't comply, it's going to be well known on this because this office is going to get a lot of attention. It's going to be very clear which hospitals are complying and which aren't. But another key reason is the city council gives out millions and millions of dollars in discretionary funding, tens of millions of dollars to hospitals for equipment all the time. And so really, should we continue to give out millions of dollars in these discretionary grants to hospitals that simply will not comply with our transparency legislation? No, I don't think we should. So I think that is another means by which we can ensure compliance.
Great, thanks. Well, we have a lot more audience questions. And as always, when we have a great panel, we're running way behind. So I'm just going to keep it going. Let's turn a little bit prospective. Let's look at the future. How do we bring hospitals up to the level of the best that are socially responsible, like Del Seaton or Denver Health or some of the others we mentioned? What policies do we need that would really move the needle? So let's talk a little bit about solutions or ideas for that. So Reed, I'm going to start with you. What could policymakers be doing to help hospitals across the board? And what obstacles are you aware of that are currently standing in the way for hospitals, whether yours or others that might want to emulate Denver Health? What are the policy hurdles?
This is a great question. Let me start with a couple of the hurdles. There are many. I think we've already referenced one here, which is that if you take an isolated lens of a hospital per se, I think hospitals feel a real competing set of demands in terms of who am I accountable to. Of course, we want to provide care to the community. COVID, I think, has reinforced the idea that profitability is really important. And so revenue cycle and how we fund healthcare in America becomes a key focus. There are lots of regulatory pressures, reporting requirements. And then, there's a game going on across the country in terms of chasing reputation and pursuit of market share. And so it's easy to get kind of mixed up in those priorities. This is where I think policymakers can help us find clarity around the priorities. And this is where I think some of the movement to go local to me makes a lot of sense. So how do we build not only partnerships, but conversations and then structures where policy setting at the local level within cities and counties really helps to put a spotlight on the things we can be doing that are most impactful to advance the health of communities. Where we have dollars, we can flow those towards incentives that get people's attention. And most importantly, we're in partnership with our policymakers to ask the question, how can we make the ecosystem we were talking about earlier more vibrant and stronger? Because a lot of hospitals, I think, will say, it's hard for us sitting in the care delivery system to solve for everything that's going on in the public schools. And that's really important. It's hard to solve for transportation. That's really important. It's hard to solve for sustainability and the impacts of climate change on certain neighborhoods. We need partners to do that. That's where our policymakers, I think, can help build bridges, invite hospitals and their leaders and their workers to the table to be part of those conversations, to sit on boards, to be invested in the policymaking process where that is allowed and there's not a conflict of interest. So that's where I would start. There are lots of other things that I think we can encourage, which I know Veronica and Julie have a bunch of expertise in.
Great, thanks. Yep. So Julie, we've touched on this a little bit. You have a little bit, but if you imagine a future 5 years out, like what are the levers, both with the new office or other things you might think of, what are the levers to get to a place 5 years out where New Yorkers have the kind of healthcare in terms of access, equity, and affordability that you're imagining?
Well, that's a great question. And I think this office is the first necessary step to get there, because if you don't know what the price is that you're about to be charged for these major medical procedures, you're really going in the dark to a hospital. We know that medical debt is one of the leading causes of debt for most people. And so this really gets to that issue. The hope with this office is that it will ensure that hospitals are disclosing the price of their various procedures, but we also get to the equity and community care piece as well. I think if you were to take a poll and you were to poll New Yorkers and say, did you know, for example, that some of the large nonprofit hospitals, New York Presbyterian or Mount Sinai, did you know that our nonprofit hospitals are receiving $1.2 billion of tax incentives? I think the majority of New Yorkers would not know that information. So by disclosure, sunlight is a wonderful cure to a lot of issues. But at the end of the day, we need to make sure that these hospitals are doing the right thing by their patients. And that is making sure, of course, that these prices are disclosed, but also making sure that they are putting the kind of investments that we need in terms of community care, because the health discrepancies and inequities for many communities are tremendous.
Great, thanks. So Veronica, when you picture a socially responsible health system in LA, what do hospitals' behaviors look like in that model? What would you like to see in there?
Well, in addition to all the other stuff we already talked about, representation and so forth, I think, we need to have something a little more stringent. Just as, I think about the way schools are expected to prepare the next generation of students. They have to have very specific metrics of success, and then look at really the challenges of the market through education. Well, hospitals should be expected to ensure that the health of their communities that they serve is at par where the way the community should be healthy. And we have metrics, all of the work you're doing. So the metrics of what it should look like is already there. How they go about it, I think, is a different thing. Patients should reflect the communities that they serve. They should have healthcare providers that actually look like them, especially when we see birth rates and birth outcomes for particularly Black mothers. And we know that evidence is showing that when you hire a Black doctor, outcomes automatically improve, not only for the same population, but for the population overall. So if we have evidence, it's really not about that. We have enough evidence to say, we know what it needs to look like. And look, you have the top 10 right in your list of how it can be done, right? And so I appreciate the metrics, especially the share fair spending. That's outstanding. And so when we have the messages of we can't afford it, we have to be able to show the metric just like that. You're saving so much money in taxes, and you would have to pay those out anyway. So what are you doing with all those savings? Community benefits, what are you doing with all of that? How are you really doing your health assessments from the hospitals? How are you really evaluating access to care? I think that's what I would like to see in hospitals in LA and across the country. Because if we really think about that metric, maybe there's a supplemental payment or something that we create, an incentive for the hospital for improving rates. around, healthcare markers, right? Like obesity, diabetes, birth rates for women of color. That would change the hospital. It would change its outcomes. I mean, people are dying in hospitals right now when they don't need to die. So I would say that would be a nice improvement.
Great, thanks. Well, I got so much more I want to ask all of you, but in the little time we have left, I'm going to turn to a few more audience questions. So first for you, Veronica, how can the community health needs assessment process be used to advance equity?
Oh, that's a great question. One of the ways in which a lot of the community health assessments are done right now is that they just look at all data, incorporate all data, maybe do a couple of groups, hire a consultant who will just duplicate the same data, and then provide the report because it's cheaper. Since it happens only every couple of years, right? It's cheaper, it turns around. A real health assessment would bring in community members to actually hear from them. What do they need? What's the possibility for partnership around healthcare? Not just how do you access and how do we do it, but what's the partnership that we need to have in order to really incorporate this guardrails around healthcare. As you said, Reed, we need to look at transportation. Well, hospitals are not going to do transportation, but who do you partner to do that? Those community health assessments could also not only look at patient, but they could look at what is the environment in which they're operating and put some metrics in place to say partnerships have to be improved so that then we can think about the ecosystem in a different way. That's not necessarily happening right now. We actually got engaged to do a community needs assessment for one of the major hospitals here in Los Angeles. And we only did one because after that, what we found was, and I'm not going to talk about who it was, but what we were asked was, can you remove some of that data that was specifically done when we went to youth, trans youth, we went to homeless youth, we did a whole assessment on what it should be included. They asked us to actually remove that from the regular report and just put it in a supplemental report. And we had to do that. And we said, that's exactly what's happening right now. And so if someone wants to improve their assessment, then truly assess what the community needs at the moment and establish some different policies so that when you do it again in a couple of 2-3 years, then we're seeing some differences and make some comparables between what did I learn 2-3 years ago? Am I learning the same thing or am I just copying the data? Because you know what? Nothing has improved. So let's just copy the data. And that's just the unethical part of it.
Yeah. Okay, really at the very tail end of the show, Reed, I think this is an interesting question, and maybe you're just new at Denver Health, so maybe this is perfect for you. How can executives in top performing hospitals help influence executives at poorly rated hospitals?
That is such an interesting question. The two things that come up for me, Vikas, are working to reinvigorate, and where we need to, I think, build new national networks where this conversation that we're having today is a regular part of the conversation across leaders in healthcare. When I think about topics, for example, at a national conference for which I just registered recently for healthcare executives, a lot of it is supply chain management. How are we thinking about reimbursement and revenue cycle? How are we thinking about existing reporting requirements and performance on the metrics? All important stuff. And yet it'd be great to invigorate that conversation. The second is, and I don't know if this is something the Lown Institute might be interested in doing. We have other constructs around the country historically where we've said places that have high performance over time, how much you study those, and how could people from those places be ambassadors to other places to sort of share the lessons learned. There may be an opportunity there to engage leaders in places who are doing this work as part of that storytelling and case study creation.
Yeah, well, we certainly have been in touch with a lot of people who are interested in that. So I think it makes a lot of sense. Here's one for me, which is, should medical staff, specifically the diversity of the staff, be included in hospital rankings? If you're asking me at Lown, I'd say, yeah, would love to do that. But that would have to be voluntary data submission. We have no access to diversity of staffing data in any way that's public and national. So we'd love to do it, but how to get there has been the vexing question for us. We could certainly, put out a survey, but then we're really subject to response rates and all those. And we don't really want to do something that is, just very shallow. So I think that that's what I would say. And that's true for a lot of metrics that many people might think of or that recommend to us that we find we'd love to do, but there's really no good way of doing it short of a, renaissance of kind of civic engagement around data. We probably do need that. A quick, very technical question for you, Julie, and then I think we're going to wrap it up. But it makes a lot of sense as pricing transparency is increased for health systems and providers. Will this even up the negotiated prices with the health plans? Is that an outcome you envision? Does that run counter to the theory of market negotiations?
So first of all, we know price transparency lowers prices, period. The states, whether it be New Hampshire, California, Massachusetts, Maryland, that have enacted hospital price transparency, all have seen costs go down. In New York, what is so important, and I was referring to this earlier, is as a city, we're spending $11 billion on public sector employee healthcare. It's simply unsustainable. And in the hearing I had on the bill, it came out that some of the New York City hospitals refused to meet with the city of New York, one of the largest procurers of healthcare of any other entity, and the hospitals wouldn't meet with them. That's outrageous. So hospital transparency will, in and of itself, force prices to go down once they're disclosed. Once we know what all the hospitals are charging for these various procedures, it allows New York City as an employer to harness its purchasing power to drive down costs. But it also allows the private sector employers to do the same.
Got it. So you're saying there, just like there's been a spiral upwards, there may be a spiral downwards. But there is a limit. I mean, I don't want to get into it. There is a limit, right? Because they have their cost structure, and it would cause a lot of disruption if they had to change that. But that's a long conversation for another time. Well, once again, we are out of time. So I want to thank you all for coming. This was our 4th social responsibility launch. We're getting more and more interest, more and more traction, and we love doing this work and getting this out there. Don't forget to subscribe to our newsletter called Hospitals on Purpose. And for all our other social media, including our brand new TikTok account, you can scan the QR code that's on the screen now. We just had a TikTok go viral, so you could check that out. And I was kind of surprised since it wasn't all that funny and didn't have dancing, but there you go. It's TikTok. Have a great day, everyone, and we'll see you next time. Thanks for being with us.